We'll be getting started soon. So our theme for today is the non-communicable diseases. So for that and for our explanation, we have our two leaders from Penn and CHOP, Doctors Farouk Deko and Dr. Hansel Otero. I'm going to give them the floor to have some opening remarks before we start our case competition.
Welcome, everybody. We're now at the sixth edition of the case competition. We're very happy to be hosting Asia again. We have a very nice list and compendium of really good cases. We had the opportunity of review all the abstracts and all of the cases ahead of time. And again, we want to thank everyone that is involved, the team that is running the show, but also the departments that sponsored this event. And pass it over to Farouk.
Yeah, I just want to add to what Dr. Otero said. We're excited to keep this competition going for years, and even as we transition team members, we continue to be committed to the spirit of this competition, which is getting trainees from around the world a platform for them to be able to share their cases and get to network with one another. And without taking much more time, I think we can go ahead and get started.
Thank you, Doctors Hansel and Farouk. We're going to go ahead and start with a set of cases. So we're going to start off with the first case, which is going to be presented by Dr. Aman from Pakistan. It's about an unusual case of duodenal obstruction due to date seeds in a 15-month-old. So let's go ahead and see the first case.
Hello, everybody. My name is Dr. Mohammed Aman, and I'm a pediatric radiology fellow in Main Aga Khan Hospital, Karachi, in Pakistan. My mentor is Dr. Wasim Mirza, and my team members include Dr. Kiran Hilal and Dr. Mina Shahid. Today, I'm going to present a really interesting case, which is an unusual case of duodenal obstruction due to date seeds in 15-month-old patient. 15-month-old, dull-looking child from small town presented to the ER with history of chronic vomiting since 7 months. She had multiple hospital visits, but she was treated conservatively, and the symptoms has worsened over time. Her examination showed signs of dehydration and weight at the lower limit, but rest of the examination was unremarkable. Her weaning started at 6 months of age. Electrolytes were sent. CBC and electrolytes were sent. She had electrolyte imbalance, which is hypermagnesemia, elevated blood urea nitrogen and creatinine, hypernatremia and hypochloremia. IV rehydration was performed, and antiemetics were administered. She was then admitted to the ward where ringalectate was infused, and she was planned for plain X-ray and the barium study, upper GI study. X-ray showed nothing. Non-specific bowel gas pattern, no pneumoperitoneum, no signs of obstruction, followed by upper GI study. Here we can see there is the contrast is outlining the stomach with multiple internal contrasts outlining the stomach. Here we can see that the multiple ill-defined, rounded filling defects in the duodenum. We took multiple spots. Here we can see there are multiple filling defects, which is oval-shaped in the dilated duodenum. The subsequent images show significantly dilated duodenum, second and third part, with multiple intraluminal filling defects. Here I have outlined the duodenum with the marker with multiple intraluminal filling defects. We reported it as there are multiple filling defects, which has resulted in the significant dilatation of the duodenum, which has resulted in this chronic vomiting. After that, endoscopy was performed, and endoscopy showed multiple filling. These filling defects were actually the date seeds. After the removal of date seeds, the patient improved significantly. I have added the companion case, which showed in the literature. Then we can see multiple filling defects. These were filling defects were actually dead seeds, which were confirmed on surgery. In our case, after the removal of the dead seeds, we saw immediate resolution of vomiting. She was discharged, and on follow-up visit, she was fine altogether. So some take-home points: consider foreign body ingested in infants with chronic vomiting even without clear history. Imaging is crucial. Barium studies and endoscopy can identify subtle obstruction. Dates use is uncommon but potential cause of obstruction and odors. Prompt intervention prevents complication like electrolyte imbalance or aspiration. So these are my references, and thanks to my member and team and institution, I am available at mohammed.aman@aku.edu. Thank you so much.
Thank you so much for that interesting case, Dr. Aman. I just want to highlight that we're going to have 20 cases shown to you today. And of those cases, we're going to have a break in between at the 10th case. And at the end of the whole presentations, we're going to have a chance to vote for your favorite case. So make sure to sign in and listen to all the cases to pick your favorites. We're going to go off to Philippines now, where we're going to have Dr. Custodo present to us about a case of leiomyosarcoma of the inferior vena cava.
Good day, everyone. I am Dr. Ed Christian G. Custodio VI from Dr. Jose N. Rodriguez Memorial Hospital and Sanitarium, Caloocan City, Philippines. And today, I will be presenting a case entitled Retrograde, a case of an inferior vena cava leiomyosarcoma. First of all, I have nothing to disclose. For our case, patient RS, 51-year-old female with 9 months history of hypogastric pain radiating to the right flank. Initial consult was done at a different institution and was requested with abdominal ultrasound and CT, which revealed a retroperitoneal mass. Due to the imaging findings, patient sought consult at our institution. The first imaging that was requested at our institution was an abdominal CT angiogram last December 1, 2021, and it revealed a heterogeneously enhancing lobulated mass measuring 6.4 by 8.9 by 9.5 centimeters. It arises from the right retroperitoneal region, from the levels of T12 down to the L3 vertebral body, in close proximity to the hepatic segment 6. It anteriorly displays the duodenum, pancreatic head and body, with noted compression of the inferior vena cava. The mass partially engages and laterally displaces the aorta, and the right renal vein is also stretched out. There is no involvement of the vertebra, adrenals, and kidneys. Primary consideration was a neoplastic process such as lymphoma. After the initial imaging in our institution, the patient underwent CT-guided biopsy and immunohistochemistry, which revealed findings of leiomyosarcoma, after which chemotherapy with a combination of doxorubicin and dacarbazine was started immediately as the first line of treatment. After 6 cycles, contrast-enhanced triphasic whole abdominal CT was done shortly after. The scan reveals no significant interval change in the size of the lobulated right retroperitoneal mass, and now with obliteration of the encased inferior vena cava. This was mentioned by Webb et al. In their study discussing the varying presentations of different retroperitoneal tumors with the inferior vena cava. It states that the presentation of an imperceptible IVC, which is image C, is the most useful sign for identifying a retroperitoneal mass as a leiomyosarcoma of the inferior vena cava. This was seen in 75% of leiomyosarcomas arising from the IVC, but not in any case with an alternate diagnosis such as metastasis, neurogenic tumors, and other sarcomas. The patient underwent further treatments with radiotherapy and chemotherapy using gemcitabine and docetaxel and underwent a series of follow-up imaging which showed further tumor size progression. From 9 centimeters, the tumor enlarged to 12.1 centimeters after the series of treatments. These findings are suggestive of disease progression and poor prognosis, which is in line with the disease course of leiomyosarcoma of the inferior vena cava. So leiomyosarcoma is the second most retroperitoneal sarcoma and are most common in the 5th to 6th decades with female predominance. It rarely affects the inferior vena cava, accounting for only 0.1% of all leiomyosarcomas, with fewer than 400 cases in the literature and known reported cases in the Philippines. This specific subtype is known to be slow-growing and has very poor prognosis, presenting usually in its advanced stages. Once the diagnosis of leiomyosarcoma of the inferior vena cava is established, upfront surgical management has been suggested in multiple literatures with the goal of achieving complete en bloc resection of the tumor along with the adjacent organs. An option to help achieve this goal is to resort on vascular grafts and reconstruction. However, if not amenable for surgery, medical treatment and palliative care could be facilitated. Okay, as a summary, we presented the case of a 51-year-old female with a large heterogeneously enhancing retroperitoneal mass with an imperceptible IVC lumen with a diagnosis of leiomyosarcoma of inferior vena cava, which was also proven by biopsy. This disease is slow-growing and usually discovered late in its course with poor prognosis. Patients with long-standing symptoms such as edema, epigastric pain, or flank pain should be screened. Aside from establishing diagnosis, imaging is also used for the assessment of tumor resectability. And if patients are amenable, upfront surgery is the treatment of choice. And that is my last slide, and here is a QR code for my references. Thank you everyone for listening.
Yet another great case. Thank you for your presentation. Okay, now we're going to go over to India, where Dr. Mary is going to present about aberrant malformation and where radiology played a big role.
Greetings from India. I'm Dr. Priyanka Medhi, a fellow in pediatric respiratory medicine at Christian Medical College Fellow, and today I'll be presenting a child with Abernathy malformation under the mentorship of Dr. Varki and Dr. Keshava. Abernathy malformation or congenital extrahepatic portosystemic shunt is a rare anomaly defined by blood bypassing the hepatic filtration through abnormal vascular connections between the portal venous system and the systemic circulation. Radiological imaging is central to diagnosis, and interventional radiology can help with definitive treatment. Our child, PK, a 9.5-year-old male, presented with history of recurrent episodes of cough with poor weight gain for 3 years with no significant past history. Alongside this, he reported progressively worsening breathlessness. His parents, over a period of 12 months, noticed development of bulbous nail tips and bluish discoloration of his nail beds. Echo and contrast CT chest done elsewhere were reportedly normal. Symptomatic management was tried for this child, but it brought no relief to him. He then presented to us and he was found to have muddy sclera, central and peripheral cyanosis, grade 3 pan-digital clubbing with no pallor or icterus, low saturation in room air, and he was undernourished. Surprisingly, examination of the respiratory and cardiovascular systems was unremarkable. A contrast echocardiogram was therefore done, and it revealed dense opacification of the left heart 4 beats after complete right heart opacification, thus indicating the presence of an extracardiac shunt. The next step was to localize this shunt, beginning with a focused evaluation of the usual areas of concern, the thorax and the abdomen. We went ahead with a CT imaging of these regions. The axial view of the CT venogram is shown here. The aorta and the IVC are marked in red and blue respectively. One can see the splenic vein and the superior mesenteric vein joining to form a large common channel. A small caliber hypoplastic main portal vein measuring about 4 mm is seen connecting to the prominent splenoportal confluence. Now let's look at the coronal section of the CT venogram. The hypoplastic thin main portal vein is seen here along with the portosystemic shunt, and as we trace the shunt cranially, it can be seen draining into the IVC, which eventually drains into the right atrium. This striking finding of a portosystemic shunt and a hypoplastic main portal vein clinches the diagnosis of type 2 Abernathy malformation. We reconstructed a 3D image of the CT venogram for better understanding. Here the portal circulation is colored in blue and the systemic circulation in green. The splenic and the superior mesenteric veins are distinctly visualized, forming a prominent splenoportal confluence to which the small caliber portal vein joins. This common channel is a portosystemic shunt, which then drains into the IVC. Moving on to the management. Type 2 Abernathy malformation can be definitively treated by endovascular closure of the portosystemic shunt. First, we attempted to measure the portal pressures via temporary balloon occlusion. Access was established via the internal jugular vein, following which the shunt was cannulated and balloon inflated. The shunt was clearly appreciated after contrast administration. Pre and post balloon occlusion pressures were measured, and a rise up to not more than 15 millimeters of mercury was recorded in the portal circulation, which is well within the safe cutoff. The portosystemic shunt was then permanently occluded using Amplezer vascular plug, and post-occlusion, the contrast could be seen only in the IVC, where pressures were recorded to be just at 7 millimeters of mercury. Once the shunt was successfully occluded, we imaged his brain. T1-weighted MRI brain image showed hyperintensity involving bilateral basal ganglia, a finding consistent with chronic manganese deposition from long-standing portosystemic shunting. Since the child was asymptomatic, chelation was not done. His liver architecture on sonography was found to be normal, with no nodular changes or evidence of hepatocellular carcinoma. His clinical outcome was nothing short of dramatic. Within a few weeks, his saturation was normal, his cyanosis resolved, breathlessness was gone, and he was thriving. This is him a year later, pink and making excellent progress on his growth trajectory. Pre-procedure, the child had grade 3 pan-digital clubbing, and post-procedure, after 12 months, there is barely a trace at all. The important take-home points from this case is that one should always suspect an extracardiac shunt in unexplained cyanosis and go ahead with the contrast echocardiography. In Abernethy malformation, radiology has a significant role to play, not just in diagnosing, but also in providing treatment. Remember to screen the brain and the liver. Early diagnosis can make a lot of difference. I'm thankful to PK, his family, everyone listening today, to the mentors and my teammates, as well as the organizers. Thank you.
Yet another great presentation. Thank you very much. That was an interesting case. We're going to go now to Vietnam, and we're going to see a case of endovascular stenting of portal vein stenosis in a patient with a recurrent gastrointestinal bleeding after pancreatic duodenectomy. Dr. Q is going to be presenting.
Okay, hello everybody. I am Dr. Kiều Vĩnh Phúc. I come from the Vinh University in Vietnam. My mentor, Dr. Thái Yong Kiều, will support me for this case. About my topic, I want to present is endovascular staining of the portal vein stenosis. A different treatment for recurrent acute GI bleeding following pancreatic duodenectomy. So we also that is the Whipple procedure. So we have the 62 years old male patient presented to the Melina during the 10 days. He also had important vascular history related to the Whipple procedure for fatal ambulatory adenocarcinoma 2 years ago, mechanical aortic valve replacement, and hypertension. About HBI, prior to 10 days of admission, the patient had 2 to 3 times of a Melina per day, and his was progressive of extraordinary breath and fatigue. That reason why he come to the hospital. On physical examination, he showed that the size of anemia with the hemoglobin is about 82 gram per liter. He did the upper GI endoscopy. It showed grade 3 esophageal with breast spot size, and we don't have the size of active bleeding. He was performing endoscopic pain ligation and medication treatment. During 4 days from admission, the patient still have the melena but mild level. But in the day 4 of the hospitalization, his melena is more severe, and he had the signs of the hypovolemic shock due to the blood loss. His hemoglobin at this time is 47 gram per liter. He did GI endoscopy again, but don't have the size of the active bleeding. He did an abdominal CT scan, so I was easily to see that it have the blood into the lumen in here, but we don't confirm the source of the bleeding in this time. Okay, when we assess the water vein system, we can see that the general collateral circulation is here, and we suspect that all the patient have the water vein stenosis is here, maybe due to Whipple procedure before. So if you want to confirm that the patient was did a portal venography, and he's also did the stent replacement treatment for this stenosis. And you can see here portal vein stenosis I noted in the yellow cycle. And here we also, that is the general collateral circulation is very clearly. And finally, that is the portal veins after stent replacement. The blood flow is very smooth. So, okay. Finally, the patient was diagnosed with severe upper GI bleeding caused by the variceal general bleeding due to portal vein stenosis. After he did the procedure, he continued to use the medication, fluid replacement, and the blood transfusion. After the 4 days of the treatment, the patient is still stabilized, and Molina is resolved completely. His hemoglobin is stabilized. Okay. He started aspirin for his stay and he was discharged. For this patient, up to now, the patient has not had an episode of melena since the recent hospitalizations here. Okay, from this case, I have some points to share with everybody. The first one, the portal vein stenosis is an uncommon cause of water hypertension, and the GI bleeding is secondary to variceal formation. The second one, the history of the abdominal surgery may be contribute to development of atopic varices at the surgical site. Follow the report of HEOC in 2015. The incidence of portal vein stenosis after the Whipple procedure is about 2.4%. And the third one, the inpatient with history of the pancreatic surgery, when you want to approach the stenosis site by surgery is very difficult. So endovascular approach in this time is preferred. And finally, endovascular stent replacement at the site of the stenosis is an effective and minimally invasive intervention that reserves the hepatocellular flow for this patient. Okay, that's all my case. Thank you for your listening.
Thank you very much. That was yet another interesting case with diverse modalities. We appreciate all the variety of cases that all our participants have submitted. Now we're going to go over to Pakistan, and Dr. Yusuf is going to be presenting to us about a renal artery stenosis that was masquerading for other renovascular hypertension on a Doppler ultrasound. So we're going to go straight to that case.
Hello everyone, I am Dr. Mohammad Yusuf, radiology resident at Aga Khan University Hospital, Karachi, Pakistan. My mentor is Dr. Kumail Khandwala, consultant radiologist. I have no disclosures. My case is aortic coarctation masquerading as renovascular hypertension on renal Doppler ultrasound. So this is a case of a 4-year-old male from low socioeconomic background with prior history of hypertension presented to the emergency with the complaint of right-sided hemiparesis for 1 week with some history of fits, raised blood pressure, and suspected renal artery stenosis on outside renal Doppler ultrasound. On clinical examination, there was ejection systolic murmur, and rest of the cardiovascular examination was unremarkable. The patient underwent a lot of lab workup for autoimmune conditions that all came out to be negative. His aldosterone levels and renin levels were also within normal limits. His initial CT brain revealed bilateral cerebral infarcts, and he underwent MRI brain, where you can see that there are acute infarcts in bilateral MCA territory. On time of flight 3D sequence, there is severe narrowing in terminal part of the right ICA. The terminal part of left ICA and entire left MCA are completely occluded. Based on the findings on MRI and high suspicion of vasculitis, a repeat renal Doppler was advised. These are selected images from the intrarenal arterial spectral Doppler pattern, where you can see that there are delayed upstrokes with increased time to peak in bilateral intrarenal arterial branches consistent with Parvus Stardust waveform morphology. In the main renal arteries, there is no focal aliasing in either of the main renal artery to suggest focal stenosis, and bilateral main renal arteries are showing normal peak systolic velocity. However, the waveform is similar to the intrarenal arterial branches, having delayed upstrokes with increased time to peak and dampening of the waveforms. So the abdominal aorta was sampled after that, which was also showing similar kind of waveform with increased time to peak. This is just a normal example of the intrarenal arterial waveform, which is showing rapid upstroke as opposed to our case, which was showing delayed upstroke. And this is a normal abdominal aortic waveform, which is again showing rapid upstroke with some early diastolic reversals, as opposed to our case, which was showing delayed upstroke with continuous diastolic flow. So all of these findings raise the possibility that there must be a stenotic lesion at the level of the heart, because if it were a case of renal artery stenosis, there would not have been any changes in waveform of the abdominal aorta. We advise further evaluation with echocardiogram. These are the suprasternal echocardiographic images where you can see that there is focal aliasing in arch of the aorta, and at the point of aliasing, there is markedly increased peak systolic velocity of more than 4 meters per second with continuous diastolic flow and a maximum gradient of 76 consistent with coarctation of the aorta. The patient proceeded for CTA to further outline the coarctation and to rule out renal artery stenosis. There is redemonstration of the post-ductal coarctation of the aorta. However, there is no focal stenosis in either main renal artery. Although bilateral main renal arteries and abdominal aorta appear diffusely narrow in caliber, and this is secondary to reduced downstream flow across the level of the coarctation of the aorta. An MRNA was also obtained to look for any findings associated with vasculitis, but there was no focal irregularity or narrowing in the major neck vessels. Patient ultimately underwent balloon angioplasty. He was clinically improved to much extent and was discharged. Coming to a little bit of discussion, the classic radiofemoral delays, vascular bruise, and blood pressure differences might not always be obvious in every case of coarctation and can be overlooked by the clinicians. Undiagnosed coarctation may lead to ischemic stroke, as in our case, and this has been reported by Mandalinakis et al. That the risk of ischemic stroke was highest with coarctation among all congenital heart diseases in younger patients with a hazard ratio of 12.8. A large study by the Picard et al. Reported the association of coarctation with premature ischemic strokes and hemorrhagic strokes with a higher prevalence of unruptured aneurysms. Even if we might consider the primary pathology to be vasculitis in our case, renal Doppler findings still helped us pointing towards the coarctation of the aorta. And then there are some case reports and case series already in the literature that have highlighted this kind of abnormal waveform pattern to be associated with coarctation of the aorta. And some elderly cases with refractory hypertension have been diagnosed with coarctation based on the initial findings of the renal Doppler. So the take-home message is bilateral, intrarenal, and extrarenal forward status flow pattern plus similar abnormal pattern in the abdominal aorta. Always think of the coarctation of the aorta. Every single vessel you are evaluating is not just a tube of blood flow. It represents interactions with the entire human body. And you can be the first person to suggest coarctation in an unsuspected and overlooked case of secondary hypertension due to coarctation, thereby saving patients from developing complications such as strokes and heart failure. Thank you everyone for listening.
Thank you very much. That was a very insightful presentation. I don't know about you, I'm learning a lot from these cases. So we're going to go next to India, where Dr. Kaur is going to present to us about a cardiac myxoma in a acromegaly patient and with stroke and microaneurysms, a Carney's complex. Let's go over to her presentation.
Hello everyone, I'm presenting a case on cardiac myxoma, acromegaly with stroke and cerebral microaneurysms, a case of Carney's complex. So the patient initially presented to us, he was acromegalic and was pre-diabetic. IGF-1 levels were elevated and clinical exam also showed multiple skin lentigens. He had a past history of ischemic stroke which was managed conservatively. And during that workup, it was revealed that he has a left atrial mass, which was excised, and biopsy revealed a left atrial myxoma. So, initially he presented to us with the features of acromegaly. So, we went ahead with the dynamic CE-MRI CELA. This is the coronal fat-suppressed T2 weighted image, which showed that there was a small, well-defined T2 hyperintense lesion in the anterior pituitary, which was also corroborated on the post-contrast scans as a differentially enhancing lesion, which was measuring 2 into 1.5 mm in the left side of the pituitary. So this was a pituitary microadenoma, which was seen in this patient. Since he also had a past history of ischemic stroke, he underwent CT angiography of the brain. The CT angiography revealed that there was a chronic infarct in the right parieto-occipital lobe, and on the arterial phase axial and sagittal, parasagittal CT arterial phase images revealed that there were multiple small areas of aneurysms and narrowing, which were involving the distal cortical branches of MCA. So, to further evaluate these focal areas of narrowing and dilatation, likely microaneurysms, a cerebral DSA was also performed. The cerebral DSA revealed these are the frontal and the lateral projections of the DSA of the right-sided ICA run, which revealed that there were multiple small microaneurysms which were involving the distal cortical branches of right MCA, and few of these aneurysms were also seen in the callosomarginal branches of ACA. They are depicted by the dashed arrow on these frontal lateral projections as well as on the 3D array projections. So, there were multiple small microaneurysms which were confirmed on the cerebral DSA. Since the patient also had clinical features of skin lentigenes and acromegaly, they were also corroborated on NCCT images. We could see on NCCT that there was diffuse thickening of the skin in the left frontoparietal region with focal areas of nodularity and calcification also. We could also see that there was diffuse thickening of the skin in the left frontoparietal region. So the clinical features of the lentigenes were corroborated on NCCT images. Other features of acromegaly also were corroborated on the sagittal bone window images, in which we could see that the patient had features of frontal bossing and the frontal sinus was also hyperpneumatized. So the combined clinical features that the patient had a macroadenoma, there were multiple cutaneous lentigenes, cardiac myxoma, and multiple cerebral microaneurysms. The complex was diagnosed as a case of a Carney's complex. So the take-home points regarding Carney's complex are that the Carney and colleagues first reported on Carney's complex in 1985 as a complex of myxomas which can be cutaneous or cardiac. There is spotty skin pigmentation and endocrine overactivity, most commonly growth hormone producing, which are the classic manifestations of this disorder. The Carney's complex is a rare genetic condition which is caused by inactivating mutation in protein kinase A on chromosome X, which can develop randomly or it can also develop in an autosomal dominant fashion. The patient may also have other features of the Carney's complex like acromegaly from growth hormone producing tumors, testicular calcification on ultrasound, thyroid carcinoma, melanotic schwannoma, blue nevus, cutaneous lentigenes, breast adenoma, cutaneous myxoma, cardiac and breast myxoma, and osteochondromyxoma. Only 2 of the above features are required to diagnose that the patient has a Carney's complex. However, if the family history is present, then only one of the aforementioned criteria is required. It is clinically diagnosed disorder based on the clinical features as we have mentioned. However, a specific imaging workup, as we have done in our case, can be done if the suspicion exists. In rare cases, only the Carney's complex will manifest as cerebral microaneurysms, which is more prevalent in the cardiac myxoma patients, as was seen in our index case. Microaneurysm development occurs more frequently in the distal cerebral vessels due to endothelium damage caused by either tumor cells spread to the vessel wall or myxoma cells causing temporary blockage of vessels, and subsequently the patients also develop ischemic strokes. The typical angiographic findings of microaneurysms are that they are multiple and they are peripherally located fusiform aneurysms. These microaneurysms are most commonly associated with ischemic infarcts, as we have seen in our case. So these are the references for my case. Thank you everyone for listening.
Another interesting case from India. Thank you very much for that presentation. That was great. We're going to go over now to Hong Kong, where we're going to see a case of atypical Kawasaki disease with a coronary artery aneurysm. This is going to be presented by Dr. Ming. Let's go to the presentation.
Good evening, Professor, seniors, and colleagues. I'm Chong Yimeng, resident from the Department of Radiology, Queen Mary Hospital, Hong Kong. My mentor is Dr. Chin Lian Han Ching, and we're presenting on a case of atypical Kawasaki disease with coronary artery aneurysm. A 3-year-old boy with unremarkable past health presented to our institute for fever for 6 days. Physical examination revealed bilateral conjunctival injection, edema of lips, and mildly enlarged left jugular lymph nodes. There was no rash, no erythema or desquamation over the extremities. Laboratory investigations were remarkable for elevated erythrocyte sedimentation rate, C-reactive protein, as well as platelet counts. Atypical Kawasaki disease was suspected, and he was subjected to serial echocardiography, showing progressive coronary dilatation. It confirmed the diagnosis, and the patient started on the intravenous immunoglobulin with improvement in inflammatory markers. He was also initiated on antiplatelet and anticoagulation for coronary artery aneurysm. Serial CT coronary angiograms were performed for monitoring. This is an axial reformated images of the latest CT coronary angiogram, demonstrating fusiform dilatation at proximal left anterior descending artery, suggestive of aneurysm formation. On another coronary reformer image, apart from the previously noted proximal LAD aneurysm, there are also 2 fusiform dilatation at proximal and mid-right coronary artery with mural calcification, indicating aneurysm formation. At the large lesion at the mid-RCA, there is eccentric hypodensity, indicating partial mural thrombus formation. And this is the volume rendering image for this CT coronary angiogram, illustrating the fusiform aneurysm at proximal LAD, as well as mid and proximal RCA. Kawasaki disease is a disease of unknown etiology, but is thought to be inflammatory in nature. The AHA guideline and the Japanese guideline differ slightly on its diagnostic criteria, but prolonged fever for at least 5 days, as well as at least 4 out of 5 principal clinical features are required for a diagnosis for a typical Kawasaki disease. Incomplete or atypical disease should be suspected when the criteria is not fully met, but clinically suspicious. Cardiac imaging should be considered in these cases to look for coronary involvement to substantiate the diagnosis. In Kawasaki disease, coronary involvement manifests as coronary artery dilatation, where proximal LAD and proximal RCA are the most common sites of involvement. For extracoronary involvement, its cardiac manifestation include myocarditis and its associated reduction in left ventricular ejection fraction, as well as pericardial effusion. Extracardiac manifestations include non-coronary artery aneurysm, as well as gallbladder hydrops. Early diagnosis allows prompt treatment for complications such as coronary artery aneurysm. As illustrated in our cases, the mural calcification would indicate underlying chronicity of the lesion. Another dreadful complication include myocardial infarction. The detection of this coronary artery aneurysm or dilatation is important, especially as an incidental finding from investigation requested for other purposes, such as a non-dedicated contrast CT thorax or abdomen, commonly requested for investigation for source of sepsis in these patients with prolonged fever. We radiologists play a pivotal role in diagnosis, including raising the suspicion as an incidental finding in proper clinical context, confirming the diagnosis as well as detecting the complication of Kawasaki disease, as well as offering surveillance imaging. These are my references, and thank you for your attention.
Thank you very much for the great case. We're going to go over now to India to hear about presentation from Dr. Chaudhary about a rare case of long segment hair-span disease with cecal volvulus in an infant.
Myself, Dr. Bhupender Singh Rao, radiology resident, Government Medical College, Surat, Gujarat, India. A rare case of long segment hair-span disease with cecal volvulus in an infant. Hirschsprung disease is a congenital condition characterized by absence of enteric ganglion cell resulting in functional bowel obstruction. While most cases present with a classical finding in contrast enema, rarely it can be associated with volvulus. Here in this case, the 9-month-old unimmunized infant with full-term normal vaginal delivery presented with progressive abdominal distension, vomiting, difficulty in passing stool since birth. On examination, infant appeared anemic and with marked distension of abdomen, with initial abdomen radiograph and UHG shows closed gaseous distension of bowel loop. Contrast intensity scan of the abdomen and pelvis was performed, which revealed massive dilated cecum, ascending colon, transverse colon with cecum abnormality located in the left hypochondrium with descending colon, sigmoid colon, and rectum appears non-dilated. Long segment Hirschsprung disease with cecal volvulus, later confirmed with intraoperative finding and histopath report. Case is this like 9-month-old unimmunized child with full-term normal vaginal delivery with progressive abdominal distension, vomiting, not passing stool since birth, and not passing stool from last 15 days. On examination, local examination, abdomen was distended, tense, tympanic, with diminished bowel sounds. Initial laboratory findings are within normal routine parameters, like WPC counts are within normal limits. Initial abdomen X-ray shows closely dilated bowel loops with its long axis towards left hypochondrium and the kidney, with giving the kidney bean appearance. X-ray lateral view showing multiple fluid levels. UHG abdomen revealed minimal ascites and gaseous distended bowel loops. Due to arising concern for distal bowel obstruction, possible ischemia or contrast intensity can obtain. CD finding, as mentioned, cecum, ascending colon, hepatic flexure, transverse colon, spleen flexure appear dilated and filled with fecal matter and gas with average diameter measuring 6 cm at cecum, 4.3 cm at ascending colon, 7 cm at transverse colon. However, shows normal wall enhancement, terminal ileocecal junction, cecum, and ascending colon noted in the left side of abdomen with minimal twisting of mesentery. Superior mesenteric artery and superior mesenteric vein shows normal relation and mild ascites shows. Above mentioned finding confirmed with intraoperative and patient underwent transfer and colostomy with distal stump closure. Colon biopsy confirmed aganglionosis with hypertrophic nerve bundles in descending colon. Here the CCT coronal view showing dilated cecum. This is the appendix. Dilated cecum in the left hypochondria with twisting of mesentery. CCT sagittal view showing non-dilated descending colon. And this is the CCT axial view where the dilated ascending colon and dilated cecum, where the cecum noted towards the left side of abdomen. Here is the dilated transverse colon, and this is the transition point at splenic flexure, where the dilated and non-dilated bowel loops are separated. This is the non-dilated descending colon, this is non-dilated, this is sigmoid colon, and this one is the non-dilated rectum is noted. Here is the intraoperative image of the bowel loops, where the transverse colon is dilated and the descending colon is the non-dilated one. And this one is the transition point. Hirschsprung disease is a congenital disorder caused by absence of enteric ganglion cells in the distal bowel leading to functional obstruction. It typically presents with neonatal period with abnormal distension, failure to pass meconium, and occasionally vomiting. The gold standard for diagnosis include contrast enema to visualize the transition zone and rectal suction. Biopsy for histologic confirmation rarely can be associated with sigmoid or cecal volvulus. Cecal volvulus is a colonic volvulus in which the mobile cecum twisted around its mesentery, often due to congenital malfixation. In our case, long-standing colonic distension secondary to Hirschsprung may be contributed to cecal hypermobility and eventually lead to cecal volvulus. This case represents a highly unusual and diagnostically significant coexistence of long segment Hirschsprung disease with cecal volvulus in an infant in association with rarely documented in the literature. and association rarely documented in the literature. While Haas-Frank disease typically causes functional obstruction, this case underscores how chronic coronary distension and abnormal bowel fixation can predispose to mechanical complications such as volvulus.
Okay, thank you for that great presentation. Now we're going to go over to Indonesia, where Dr. Nugro is going to be presenting a series of cases where we seek to rediscover scurvy.
Hello everyone, I'm Muhammad Yanuar Prasetyo Nugroho presenting from Indonesia. It's an honor to walk you through our case series titled Rediscovering Pediatric Scurvy, Imaging Insight from 3 Cases. First, I would like to thank my mentors, Dr. Ido, Dr. Yani, Dr. Gita, and Dr. Austin for their invaluable guidance throughout this project. Let's begin. 3 children aged 3 to 5 present with progressive limb dysfunction from limping to immobility, developing over weeks to months. All had diets lacking fruits and vegetables. Physical exam showed gingival bleeding, limb edema, muscle wasting, and hypotonia. Labs then revealed anemia, low albumin, and mild electrolyte imbalance. Scurvy wasn't considered until symptoms persist and nutritional history was re-evaluated. Initial CT in one patient showed right femoral head dislocated from the acetabulum with a chronic transverse neck fracture and craniolateral displacement. On the left, a subtle intertrochanter cortical break was noted. Due to soft tissue swelling and suspect hematome, ultrasound was performed and revealed subperiosteal heterogeneous hypoechoic collections along the femur and tibia, consistent with subperiosteal hematome. A suspect epimetaphyseal fracture was also seen in this USG. X-ray then confirmed scurvy, with classic signs including Wimbergering and Pelkan spur. In addition, we observed complications such as distal femoral epiphyseal slip and hip subluxation with superolateral shift. In another case, scurvy signs were observed, and a healed physeal fracture and limb shortening further support prolonged undiagnosed scurvy. This X-ray from the third patient shows hallmark scurvy signs, the white line of rankle or dense metaphyseal calcification, tumor field or scorbutic zone, which is loosened band beneath, Pelkan spurs or big metaphyseal margins, Wimbergering, which is peripheral epiphyseal ossification, and lastly, subperiosteal hemorrhage. These rarely occurring signs strongly indicate impaired bone formation and defective collagen synthesis due to vitamin C deficiency. Next, post-treatment images from 2 patients are shown. The first underwent surgical fixation, the second received a back slap, the third was treated conservatively with vitamin C and minerals. All patients showed clear clinical recovery. So, how did it all begin? We encountered 3 young children with progressive limb weakness, ranging from limping to complete immobility. Initial diagnoses include neuropathy, chronic illness, and TB relapse. Early imaging, including CT, failed to reveal the cause. With vitamin C testing unavailable, radiology clues become essential. Radiographs later showed Frankel line, Wimbergering, Pelkan spur, and subperiosteal hemorrhage, confirming scurvy. So, scurvy mimics arthritis, osteomyelitis, or malignancy, which can Kinlet et al., a child was misdiagnosed with osteomyelitis and received unnecessary antibiotics. All patients were initially labeled with renal failure, neuropathy, or trauma. Early recognition avoids prolonged morbidity and overtreatment. Presenting subtly with musculoskeletal symptoms, this elusive condition has made a quiet comeback. What once plagued sailors now walk quietly through pediatric wards. In Rakers-Dover et al., 2024 report a 3-fold increase in pediatric scurvy cases from 2016 to 2020 in the United States. Thankfully, rising awareness is turning delayed diagnosis into timely recognition. Following the COVID-19 pandemic, pediatric scurvy gained renewed clinical visibility, This rise in publications since 2020 reflects not only increasing cases but growing awareness, making diagnosis easier and more prompt across settings. So last, scurvy continues to exist even in modern, well-equipped hospitals. Its early symptoms often mimic infection, arthritis, or trauma, making it easy to miss. When lab confirmation isn't available, classic radiologic signs remain our most reliable guide. Recognizing it early leads to faster recovery and fewer unnecessary interventions. After all, scurvy isn't rare, it's just rarely considered. Thank you for your attention.
That was an interesting case series. Everyone will learn to look out for scurvy next time you do your MSK cases. So we're going to go to the last case before our 5-minute break, and it's going to be from Vietnam, and Dr. Du is going to be presenting about a superior mesenteric artery syndrome, a radiology guided rescue.
Good day, everyone. My name is Phao Ho Thanh Đức, a medical undergraduate from Vinh University, Hanoi, Vietnam. It is my honor to present this case, mentored by Dr. Phan Hai Thanh from Huế Central Hospital. Today, I will present a case of superior mesenteric artery syndrome. Our patient today was a 27-year-old woman who lived 10 years with vague upper GI symptoms. She had postprandial fullness, epigastric discomfort, and nausea. She was diagnosed with GERD, treated with PPIs, but her thin body was dismissed as aesthetic based on her history taking. But 4 months before admission, her condition worsened. She had intractable vomiting, early satiety, and a 10 kg, which is around 22 pounds weight loss. On admission, her BMI was 9.3. She appears dehydrated, hypokalemia, and biochemically unstable. First, we start with fluoroscopy. This image here reviewed marked dilatation of the stomach and proximal duodenum with delayed contrast transit through the third portion of the duodenum. There was an abrupt tapering marked by the highlighted in red here, which suggested a cutoff point just before the duodenum crossed the midline. The next step was the contrast-enhanced CT scan. There was a clear transition point at D2 with sudden narrowing marked by the blue arrow here, and we can see oral contrast stagnating proximal to the lesion. On the coronal view, we can see a massively distended stomach and proximal duodenum, and again, abrupt narrowing at D3. Moving down a bit, we can see the SMA aorta distance measured only 4.57 millimeters, far below the normal threshold of 8 millimeters. But the real breakthrough came from the sagittal CD reconstruction. We choose this because we want to measure the aortomesenteric angle. The aortomesenteric angle is narrowed to just 18.35 degrees, confirming the vascular compression of D3. At this point, the diagnosis was clearly superior mesenteric artery syndrome based on some criteria. First, we can see marked dilatation of the first and second portion of the duodenum with gastric distension. Secondly, there is an abrupt compression at the third portion of the duodenum. Third, we can see the reflux of contrast proximal with little to no flow beyond D3. And finally, the diagnosis is confirmed by vascular measurement on sagittal CD reconstruction. So, regarding her treatment, given the patient's ongoing malnutrition, failure to respond to conservative therapy, we decided she should undergo a laparoscopic duodenojejunectomy. Her post-operative recovery was smooth. On POD day 1, her NG tube was removed, and by day 2, she can tolerate clear liquids without nausea or vomiting. On day 3, she can eat soft diets. She reports for the first time in months that she felt full without discomfort. On day 4, a contrast study confirmed pattern anastomosis with free flow of contrast into the jejunum and no signs of obstruction or leak. And finally, by day 5, she was discharged home and she reported she can finally able to eat, retain nutrition, and begin regaining weights. Finally, SMA syndrome is really, really rare, but it is very lethal if missed. It can lead to malnutrition, severe electrolyte disturbance, and even death due to organ failure. Its symptoms can mimic a lot of disease like eating disorders, peptic ulcer disease, GERD, or functional dyspepsia. In young women, like this case, these symptoms are frequently attributed to eating disorders, depressions, or anxiety-related GI distress. In practice, this often leads to delayed imaging and repeatedly empirical treatment. CT scan with surgical reconstruction is the most definitive and non-invasive diagnosis tool because it allows us to measure the aortomesenteric angle as well as the aortomesenteric distance. Finally, while initial management includes nutritional support, but definitive treatment is surgical restoring with a success rate from 80 to 90% according to literature. So that is the end of my presentation today, and thank you all for your attention.
Okay, we're going to take a break after this great case. So this was our 10th case. We're going to have 10 more cases, and we're going to take 5-minute break where you guys are going to be able to access
Good day, everyone.
This QR code. Feel free to scan this QR code and give us your feedback. And remember to stick to the end of the show so that you get a chance to vote for your favorite case, because we'll have a People's Choice Awards at the end of the presentations. We'll be back after 5 minutes. Okay, everyone. Thank you for sticking out for the next group of presentations. So we're going to start on our 11th case. So this case is going to be from India, and Dr. Chalal is going to be presenting about an unusual age for an unforgiving disease, a gallbladder cancer in a child with diabetes. So let's go straight to the presentation.
I extend my warm greetings to everybody present. Today I, Dr. Hitakshi Chahal, Junior Resident from Department of Radiodiagnosis, Savai Mansingh Medical College, Jaipur, Rajasthan, India, will be presenting about the non-communicable endemic disease in my region. My mentors are Dr. Ankita Gupta and Dr. Nauratmal Kumawat. The title for my presentation is An Unusual Age for an Unforgiving Disease, Gallbladder Cancer in the Young Diabetic. First, we'll discuss about the clinical presentation and the laboratory evaluation. A 30-year-old female presented to the outpatient department with a 1-month history of right upper quadrant abdominal pain, progressive jaundice, pruritus, clay-colored stools, anorexia, and significant weight loss. She belonged to the GB cancer belt area and the low socioeconomic strata. On examination, icterus and pallor were present, tenderness was seen in right upper quadrant, and no ascites was there. On laboratory investigations, the blood sugar was elevated, the total bilirubin, gamma-glutarate transferase, and alkaline phosphatase were elevated. Simultaneously, CA19-9, CA125, and LDH was significantly raised. On MRI imaging, we could see T2 hyperintense mass lesion involving hepatic segments 4A, 4B, 5, and 8 of the liver extending to the porta hepatis. The gallbladder is seen distended with multiple calculi. The mass is infiltrating the cystic duct, biliary confluence, and right hepatic ducts, causing type 3A biliary obstruction. On diffusion-weighted imaging, we could see anterior capsular extension, peritoneal carcinomatosis, and skeletal metastasis. Multiple metastatic lesions were noted in the liver, peritoneum, bones, and lymph nodes. We had a triple phase CT examination done and found that there was an enhancing mass which was encasing the GB on arterial phase CT, and the gallbladder was distant with multiple hyperdense calculi. The lesion was encasing the hepatic artery and abutting the right portal vein. We had a USG guided biopsy done, and we found that the findings were consistent with adenocarcinoma. A diagnosis of metastatic biliary tract adenocarcinoma was made, likely with the gallbladder as primary. The patient underwent conservative management. She underwent percutaneous transhepatic biliary drainage for symptomatic relief and was discharged in a stable condition. She was further planned for a palliative oncology referral. In northwestern Rajasthan, gallbladder carcinoma is influenced by several regional risk factors, including diabetes, pigment gallstones, and a higher prevalence among females. The disease also tends to occur at a younger age in this population, indicating an early onset. The contributing elements include genetic predisposition, arsenic-contaminated water, typhoid infections, poor sanitation, and mustard oil adulterated with carcinogens like sanguinarine. Low fiber, high fat diets and low socioeconomic status further compound the risk. This interplay highlights the urgent need for region-specific public health strategies, early screening, and increased community awareness. Thank you. These are my references.
Thank you very much for that interesting case and an interesting epidemiology that we are learning about. Okay, now we go off to Pakistan, where Dr. Zubair is going to present about a twisted fate, a rare case of synchronous bilateral ovarian torsion in an infant with persistent cry.
Hello everyone, my name is Dr. Nashmia Zubair. I'm a Year 4 radiology resident at Aga Khan University Hospital, Karachi, Pakistan. My mentor for today's case is Dr. Shaista Afzal. She's an associate professor at Aga Khan University Hospital. She's also serving as a program director, Women Imaging Fellowship. My team members include Dr. Khabar Bilal, he's a Year 2 resident, and Dr. Saad Qureshi, he's a Year 4 resident. My case today is Twisted Fate, a rare case of asynchronous bilateral ovarian torsion in an infant masquerading as persistent cry. I have no disclosures related to this work. A previously healthy 3-month-old female was brought to our emergency department with persistent unexplained crying for several hours. The infant was afebrile with stable vital signs. Her physical examination revealed generalized abdominal tenderness, though rest of the systemic evaluation was unremarkable. Initial laboratory tests showed a mild neutrophilic leukocytosis with normal inflammatory markers and biochemistry, warranting further evaluation for intra-abdominal pathology. Her targeted pelvic ultrasound identified an enlarged edematous right ovary that corresponded to a volume of 6.5 cc, located in the cul-de-sac with peripherally arranged follicles and adjacent free fluid. Color Doppler assessment was limited due to excessive motion. However, ultrasound findings raised strong suspicion of ovarian torsion. Normal left ovary and uterus were seen as indicated by orange and purple arrows respectively. Diagnostic laparoscopy followed by histopathology confirmed gangrenous right ovarian torsion necessitating right salpingo-oophorectomy. Post-operative recovery was uneventful for this patient. Later, in less than 2 months, this patient returned to ER with similar complaints of irritability and excessive crying for a day. The infant was again afebrile with stable vital signs. The physical examination and systemic evaluation was again unremarkable. Transverse and longitudinal grayscale ultrasound images show enlarged edematous left ovary with somewhat peripheral follicular distribution but preserved vascularity. Findings were suggesting a torsion-detorsion scenario. CT performed corroborated left ovarian enlargement for age without acute findings as indicated here by an orange arrow. Given clinical concern for torsion-detorsion, the patient underwent laparoscopic left oophoropexy. Intraoperative findings revealed a viable edematous left ovary without torsion. The infant was discharged in a stable condition. So ovarian torsion is extremely uncommon in neonates and infants, particularly asynchronous bilateral torsion, with only isolated case reports in literature. Right-sided predominance is observed due to longer utero-ovarian ligament and limited space from the sigmoid colon on the left. Infants may lack specific symptoms. Here, persistent crying was the only consistent feature across both episodes. Ultrasound remains the first-line modality even when color Doppler flow is unreliable. Sonographic clues include enlarged ovary, peripheral follicles that exhibit string of pearls sign, echogenic stroma, and adjacent free fluid. Ovarian volumes greater than 6 to 8 cm cube in premenarchal girls are suggestive of torsion. Probe tenderness adds diagnostic value. Advanced imaging such as CT and MR may be supplementary when findings are equivocal. So this case highlights an exceedingly rare diagnosis, asynchronous bilateral ovarian torsion in an infant manifesting as isolated persistent crying. Radiologists must consider torsion in afebrile female patients with unexplained irritability, abdominal discomfort, and other nonspecific symptoms. Timely recognition and intervention are critical to avoid irreversible ovarian loss and averting life-threatening systemic complications. These are my references, and thank you so much.
Thank you very much. Yet another interesting pediatric case from Pakistan, and we appreciate everyone in the audience showing their support throughout everyone's presentation. I hope you're enjoying our cases as much as we are. We're going to go now to Hong Kong, where Dr. Vika is going to present about a rare cause of reduced limb movement in infants.
Good morning, everyone. I'm Tang Fika from Hong Kong Children's Hospital, and today I have an interesting case of an infant presenting with reduced limb movement. This is a 4-month-old female infant who presented with a 2-month history of reduced left upper limb movement. She had a history of BCG vaccination complicated with abscess formation in the same arm, so the initial diagnosis was infection of some sort. However, the tests for mycobacterial infections were negative, and the serum white cells as well as inflammatory markers were normal. Metabolic disease screening was also performed, which was negative. The initial radiographs were quite striking, and as we can see in the left shoulder, there are multiple amorphous and cloud-like calcifications around the shoulder joint. And of note, there is no erosion seen in the neighboring bones. MRI was also performed, which showed multiple tiny lesions at the glenohumeral joints, which are T1 and T2 weighted hypointense. And in SWI images, we can see the susceptibility artifacts, which are suggestive of calcifications. Contrast-enhanced MRI was also done, which showed enhancing synovial thickening suggestive of synovitis. And again, we can see the calcifications within the joint. So based on these imaging findings, do you know what the diagnosis is? This is actually a rare case of tumoral calcinosis presenting in infancy, which was confirmed by open biopsy of the synovium. Tumoral calcinosis is an uncommon condition that is caused by deposition of calcium salts in the juxtaarticular soft tissues. And these patients typically present during the first or the second decade of life. And they would present with painless and firm masses, and when large enough, these can cause limitation in the range of motion. These can either be in the primary form, which can be sporadic or inherited in autosomal recessive manner, and they can also be secondary to disorders such as endocrine and metabolic conditions. Diagnosis is usually based on clinical, biochemical, and very importantly, radiological findings. As illustrated in this case, there are lobulated or cloud-like and amorphous calcifications at the juxtaarticular soft tissues. CT would be more superior in demonstrating calcifications, and sometimes the typical sedimentation sign would also be seen. Of note, lack of erosion in the adjacent bones is very important in distinguishing this from the other more common differential diagnoses such as infections as well as neoplasms. MRI would typically show calcifications, which would be seen as susceptibility artifacts in SWI images, and these would be low in signal intensity in T1-weighted sequences. In T2-weighted sequences, these can either show diffuse low signal or nodular high signal intensity. Not very commonly, pathological diagnosis would also be used, as in this case. I would also like to point out sedimentation sign, although it's not seen in this case. It is a very typical finding and is caused by the sedimentation of calcium salts, which would cause fluids and also calcium layering within the cystic lesion. Management would be by physiotherapy or surgery, And in our case, arthroscopy was performed mainly as a diagnostic purpose, but we also performed drainage of the juxtaticular material. And we can see in the postoperative X-ray that the calcifications around the joints are no longer seen. So in conclusion, we illustrated a rare case of intra-articular tumoral calcinosis presented in infancy. And we also demonstrated the diagnostic dilemma that would commonly be seen in tumoral calcinosis because of the rarity of the condition, as well as overlapping imaging features with other more common conditions. The very non-specific clinical presentation, especially in pediatric patients, also contributed to the difficulty in diagnosing this condition. So it's very, very important to remember that other clinical teams, as well as the pathologists, also play a very important role in the diagnosis of this condition. So this is the end of my presentation. Thank you.
Thank you very much for that very interesting case from Hong Kong. Let's move now back to India, where we're going to see a case of Proteus syndrome with multi-system involvement, imaging findings, and clinical implications. And this is going to be presented to us by Dr. Nikudar from India. Let's go to that presentation.
Proteus syndrome is a rare progressive overgrowth disorder, primarily affecting various tissues of mesodermal origin, including but not limited to the skin, connective tissue, bone, blood vessels, and the nervous system. The striking feature is the absence of manifestations at birth, followed by relentless progression in childhood leading to severe disfigurement. Hello, I'm Dr. Zuini Gudkar, a second-year resident at the Department of Radiodiagnosis at St. GS Medical College and KM Hospital. My mentor is Dr. Himangini Thakkar, professor and head of the department. We present a case of a 16-year-old female, a high school student residing in rural India, who presented with acute shortness of breath, chest pain, and back pain. She had history of multiple similar episodes with hospital visits and admissions in the past, and on inquiry, she had a complicated and long-winding clinical history, starting in 2011, when she was operated for ovarian serous cyst adenoma at 2 years of age. In 2019, she had a visit for fever, cough, and breathlessness to the pediatric emergency room. In 2023, she came with acute abdominal pain and vomiting. And by 2024, over a course of 5 years, she had had multiple hospital visits for acute shortness of breath and chest pain. Examination revealed a hard swelling over the left supraorbital region, severe kyphoscoliotic deformity of the spine, macrodactyly hyperpigmented skin patches over her hands, dilated and tortuous varicosities, and cerebriform plantar hyperplasia of the left foot. These are clinical images of our examination findings: left supraorbital swelling, asymmetric macrodactyly affecting the right hand more than the left, hyperpigmented patch over the dorsal aspect of the left hand, and cerebriform connective tissue nevus over the plantar aspect of the left foot. Plain radiographs show lucent areas in the lung with paucity of vascular markings, hyperostosis of the left frontal bone, and asymmetric macrodactyly and calcified soft tissue overgrowth over the digits of the right hand. High-resolution CT scan of the chest done in 2024 shows multiple subpleural bullae and areas of air trapping. Contrast-enhanced CT scan of the abdomen done in 2023 shows acute thrombosis of the portal vein and expansion of its lumen, and a CT pulmonary angiography shows partial lumen occluding thrombosis of pulmonary arteries. CA-125 levels were raised in 2011 when she was operated for serous cyst adenoma, but currently the levels were normal. MRI pelvis showed a multiseparated cystic lesion in the left adnexa and multiple T2 hyperintense, serpentine, dilated vascular channels in the pelvis with T2 hypointense foci suggestive of phleboliths. Ultrasonography of the lower limbs showed multiple dilated, tortuous varicosities, superficial veins, as well as dilated deep veins, which were compressible, but there was visible sluggish flow. The patient was diagnosed with Proteus syndrome in 2019 when she was admitted and treated by the pediatric department for pneumonia. A CTPA was done which revealed partial lumen occluding pulmonary thromboembolism, and the patient was then started on tablet warfarin. An ED visit in 2023 for abdominal pain showed acute portal vein thrombosis, which prompted further workup, including warfarin mutation studies, and this revealed subtherapeutic INR with a homozygous mild GG genotype for the VKO-RC1 gene. Following this, the warfarin dosage was increased to meet the requirements. and there were multiple emergency department visits for spontaneous pneumothoraces, which were managed by a pulmonologist by inserting ICDs, incentive spirometry, and lung expansion exercises. Currently, pleurodesis is planned for the patient given the recurrent pneumothoraces. Proteus syndrome is a rare progressive disorder caused by somatic mutation in the AKT1 gene. However, molecular genetic testing is not always necessary due to mosaicism, and a mutation will be only detectable in the affected tissues. In low resource settings, genetic testing may be skipped and diagnosis can be made only on the basis of general and clinical criteria. The necessary general criteria which must always be met include mosaic distribution, sporadic occurrence, and progressive course, which were all present in our patient. In addition to this, the clinical criteria were also met, including cerebriform connective tissue nevus, skull hyperostosis and kyphoscoliosis of the spine, bullous emphysema, pelvic vascular malformation, and ovarian serous cystadenoma, and pulmonary embolism. A minimum of 15 points is required when you don't have molecular genetic testing available, which were met in our case. Treatment involves multidisciplinary care involving orthopedic interventions for overgrowth, rehabilitation, surgical correction of deformities, dermatologic manifestation of skin lesions, thrombosis and tumor monitoring, and pulmonary support for cystic disease. Developmental and psychosocial support for the patient and the caregiver are necessary. Given the lifelong need for frequent imaging in Proteus syndrome, often starting in early childhood, adhering to the ALERA principle is critical to minimize cumulative radiation risks. And as radiologists, our role in multidisciplinary care should not be limited to diagnosing, but should also include optimizing protocols, employing dose reduction strategies, advocating for alternative modalities whenever possible to ensure diagnostic efficacy while prioritizing patient safety. These are my references, and I thank you for your time.
Yet another insightful presentation with a lot of learning lessons from India. Now we're going to go to Pakistan, where we're going to hear about a story of price of tradition for a patient with a preventable thalassemia in a 16-year-old. So this is going to be presented by Dr. Bilal, and we'll go straight to his presentation.
I am Dr. Khabar Bilal, resident radiology from Aga Khan Hospital, Karachi, Pakistan. My topic of presentation is the price of a tradition, a preventable thalassemia tragedy in a 16-year-old survivor. My mentor is Dr. Naila Nadeem and my team members are Dr. Ahmed Raza and Dr. Ahmed Jadoon. I have no conflicts of interest related to this presentation. A 16-year-old boy with a known diagnosis of thalassemia major confirmed with genetic testing was receiving regular blood transfusion since diagnosis. Presented with progressive upper abdominal pain and visible distension. He belonged to a low socioeconomic background. Their parents have a consanguineous marriage and there was no history of premarital genetic testing for the thalassemia. On physical examination, patient was thin and mildly pale, and the abdomen was distended with palpable spleen and liver. There were no signs of peritonitis or acid. Ultrasound liver and gallbladder showed calculus in the gallbladder representing cholelithiasis without signs of acute cholecystitis. Liver and spleen were also enlarged. These are the classic signs for the chronic hemolysis and extramedullary hematopoiesis. 4 months later, patient presented with right thigh pain, swelling and back pain. The swelling was hard in consistency and associated with unintentional weight loss. Radiograph of the femur in which we can see that there is permeative type of the lesion in the distal diaphysis of the femur with cortical thinning and periosteal reaction. Associated soft tissue swelling is also noted. Radiograph of the spine in which we can see that there is lateral deviation of the curvature of the spine with Cobb's angle more than 10 degrees representing scoliosis. Liver and spleen are also enlarged on this X-ray. These imaging findings and clinical history raised a red flag. Patient undergone for the MRI in which we can see that there is diffuse hypointense long bones secondary to thalassemia, abnormal heterogeneous signals in the distal diaphysis of the femur. These are predominantly T1 hyperintense with double density line in the proximal segment, and the post contrast images shows enhancement in the musculature as well as in the medullary region. Periosteal and the parosteal collections are also seen with diffusion restriction. These are the imaging findings suggestive of osteonecrosis with early osteomyelitis. Due to red flag, patient undergone for the biopsy and histopathological findings were consistent with osteonecrosis, and osteomyelitis. Culture and sensitivity showed moderate growth of Enterobacter species. Antibiotic was started at this time. Patient undergone for the echocardiography, in which we can see that there is mild left ventricular hypertrophy. Follow-up MRI showed previously noted heterogeneous signals are more conspicuous on current examination with cortical erosions. On the axial images, this intraosseous disease is communicating with the musculature and the subcutaneous tissue, making a cloaca, and diffusion restriction was also positive in this lesion. These imaging findings are the classical findings for the chronic osteomyelitis. Patient undergone for the bone age and osteoporosis assessment. Bone age according to the GP method was 12 years and 6 months, which was behind the given age. A magnified image showed medullary expansion with coarse trabeculation and cortical thinning. These are the classic imaging finding for the marrow hyperplasia. And the DEXA scan showed severe osteoporosis with higher risk of fracture. Patient is on regular follow-up in our hospital and is being managed with blood transfusion, iron chelation therapy, supplements, and fracture prevention counseling. Family has now engaged in genetic counseling with growing awareness of carrier screening. These are take-home points and recommendation from my presentation. Beta thalassemia major is a life-threatening condition. It is endemic in Asia, especially in Pakistan, with high prevalence rate, especially in consanguineous marriages, just like in our case, due to traditional and cultural beliefs. Developed countries prevented this condition through early screening and genetic counseling. Radiologically, this case is a unique case showcasing multiple skeletal and systemic complications in a single thalassemia patient. In my suggestion, radiologists of the Asia must play their role in preventing this condition and uncovering the social cost of delayed awareness and screening through displaying these grave complications. A final reminder that preventing one case can spare a lifetime of suffering. Imaging must become a voice for change. These are the references for my presentation.
Thank you very much for that rather different presentation on hematologic conditions. So we're going to go now to Vietnam, where Dr. Phuong is going to be presenting about pediatric tumors presenting in adults. So we're going to go to the presentation.
Hello everyone, my name is Thanh Huỳnh Ngọc Phương, a BGY1 radiology resident from Vinh University, Hanoi, Vietnam. I will talk about when pediatric tumors present in adults, a case of hepatic undifferentiated embryonal sarcoma. So our patient, a 33-year-old female, presented in October 2024 with right hypochondral pain. Abdominal ultrasound and MRI revealed a large hepatic cyst and moderate ascites suggestive of fascioliasis. Despite negative drainage of cytology, she received empiric antiparasitic therapy. So 2 months later, symptoms worsened and contrast-enhancing CT showed minimal change. She underwent central hepatectomy and cholecystectomy. During operation, a well-encapsulated cystic mass was found. Initial histopathology suggested synovial sarcoma, but she declined adjuvant treatment. By May 2025, recurrence led to re-evaluation and revised immunohistochemistry and confirmed the final diagnosis of undifferentiated embryonal sarcoma of the liver. Due to declining condition and financial constraints, she refused further oncologic treatment. For her lab test, the white blood cell count was not elevated, especially eosinophils consistently remained within the normal reference range. Other related lab results were largely non-specific, presenting only mild and clinically insignificant elevations. So the October 2024 abdominal MRI revealed a large cystic mass within the right hepatic lobe. This lesion contained multiple cystic components with some demonstrating fluid levels. The cyst exhibit heterogeneous signal characteristic primary hyperintensity T2 weighted and restricted diffusion on the WY-ADC map. Further analysis via post-contrast MRI provided additional crucial insights. The lesion demonstrated minimal to no contrast enhancement during both the arterial and venous phase. Importantly, a distinct enhancing capsule was observed specifically on the delay phase. As indicated by the orange arrow, these characteristics are highly suspicious for a hepatic hydatid cyst. So the contrast performed in December 2024 show minimal changes compared to previous imaging. It confirmed the presence of a large cystic mass containing internal solid components and septation, demonstrating poor or even no contrast enhancement. Furthermore, the adjacent hepatic parenchyma exhibited mild hypoenhancement relative to surrounding liver tissues. The findings provide additional characterization of the lesion. So the ultrasound and the contrast intensity from May 2025 confirmed a large recurrent cystic lesion. This lesion now presents with solid and septated components, demonstrating intense heterogeneous enhancement. Additionally, new findings include intra-abdominal fluid indicated by the orange arrow and multiple heterogeneously enhanced peritoneal and mesenteric nodules. The largest of these nodules is located in the right periumbilical area, marked by the green arrow. So UESL is a rare aggressive hepatic tumor primarily seen in children, typically presenting as a large solitary right lobe mass with non-specific abdominal pain. Lab tests and common tumor markers are usually normal. Imaging reveals a heterogeneous mass with mixed solid and cystic areas. MRI may show a fluid levels. So consistent with USL, our adult patient exhibited similar clinical imaging features. This highlights USL deceptive radiological profile, often mistaken for benign cystic entities like hydatid cyst, as initially occurred in our patient. This misdiagnosis led to diagnostic delays and inappropriate initial treatment. So pathologically, USL is a diagnosis of occlusion. The initial misinterpretation as synovial sarcoma in December 2024 was due to overlapping immunophenotypes and USL rarity in adults. Upon recurrence, repeat immunohistochemistry meticulously ruling out other tumors confirmed USL, characterized by a specific marker pattern. So this case illustrates the diagnostic complexity of rare hepatic tumors in adults, particularly in undifferentiated embryonal sarcoma of the liver. Although this tumor primarily affects children, it can occur in adults and should be included in the differential diagnosis of hepatic masses. The tumor's non-specific clinical, radiological, and pathological features contribute to prevent misdiagnosis. So this also provides valuable insight to help us to improve early recognition and avoid diagnostic delays in adult patients. So this is our reference. Thank you for your listening.
What an interesting case, showcasing different types of malignancies in this case presentations where we're speaking about non-communicable diseases and their rise. And we appreciate all the audience support. We appreciate that we are supporting your fellow participants. Let's go to the next case now. So this case is going to be from India, and Dr. Lemani is going to present about a rare case of Rosai-Dorfman's disease.
Good evening, ladies and gentlemen. I'm Dr. Swaksh Navani. I'm a third-year resident in the Department of Radiology at St. GS Medical College and KEM Hospital, Mumbai, India. My mentor is Dr. Hemangini Thakkar. I have no disclosures. My topic for today's presentation is a rare case of Rosai-Dorfman disease. The objective of the presentation is to elucidate the various imaging findings seen in our biopsy-proven case of Rosai-Dorfman disease in order to enable young radiologists like ourselves to diagnose this disease in our future practice. Clinical brief. A 30-year-old gentleman presented to the emergency department of our hospital with complaints of insidious onset of breathlessness and stridor. ENT examination done on-site for the stridor revealed normal visualization of both vocal cords. The patient also had a chronic history of painless neck swelling, bipedal edema, and bilateral painless proptosis. Due to the painless nature of these complaints, he had not been evaluated for the same previously. Labs showed raised serum creatinine indicative of some kidney injury. The patient was subjected to an emergency contrast-enhanced CT of the neck and thorax for evaluation of the cause of stridor. Axial and coronal contrast-enhanced CT of the neck and thorax showed well-defined, homogeneously enhancing soft tissue in the subglottic region of the larynx, causing severe airway obstruction, and enlarged homogeneously enhancing cervical lymph nodes extending into the superior mediastinum in the right paratracheal region. The patient also had left paravertebral posterior mediastinal lymphadenopathy of similar morphology. Following this, the patient was subjected to an ultrasound examination of the abdomen, followed by a contrast-enhanced CT to demonstrate the cause for the rising serum creatinine. Coronal and axial contrast-enhanced CT of the abdomen showed homogeneously enhancing soft tissue, encasing both pelvic junctions and extending along the proximal ureters with mild upstream hydronephrosis. The patient was then evaluated for the proptosis. Coronal T2 and T1 fat suppression contrast-enhanced MRI of the orbits showed T2 heterogeneously hyperintense, bulky lacrimal glands with enhancement confined to the glands without involvement of the surrounding fatty tissue. There was no involvement of the intracoronal space of the orbits either. Axial T2 and T1 fat suppressed contrast-enhanced MRI of the brain showed hypointense, heterogeneously enhancing lesion in the choroid plexus of the trigone of the right lateral ventricle. Following this, the patient underwent a Waters view radiograph and a CT PNS, which showed bone remodeling with ground glass appearance of the walls of both ethmoid and maxillary sinuses with absence of pneumatization. Course of treatment. The patient underwent an emergency tracheostomy for the stridor in view of the subglottic stenosis and showed significant clinical improvement following this. Imaging differentials included differentials for multisystemic involvement with lymphadenopathy, which include and were not limited to lymphoma, IgG4-related granulomatous inflammation, and multicentric Castleman disease. The patient underwent an ultrasound-guided biopsy of the left periureteric soft tissue. Histopathology revealed emperipolesis with histiocytic proliferation, and immunohistochemistry markers were positive for CD68 and CD163 and S100, which confirmed the diagnosis of Rosai-Dorfman disease. The patient was counseled for a benign disease course. The patient underwent an imaging-guided percutaneous nephrostomy for the rising serum creatinine. Steroid therapy was initiated, and the patient is currently under conservative management. Discussion and take-home points. So as we have seen, Rosai-Dorfman disease is a rare, non-Langerhans cell histiocytosis. It can manifest either in the most common form, which is multifocal, painless lymphadenopathy, or in a multisystemic form. Common sites of involvement in the body, apart from the lymphadenopathy, include the paranasal sinuses and orbits, which are the most common sites in the head and neck region, the kidneys in the abdomen, and the skin. Imaging is vital in screening for involvement of asymptomatic organs, in demonstrating the multisystem solid organ involvement, and guided biopsy for histopathological confirmation. The mainstay of diagnosis is histopathology, showing histiocytic proliferation with emperipolesis and CD68 and CD163 immunohistochemistry marker positivity as seen in our patient. The prognosis is favorable, often with a self-limiting course and with good response to steroid therapy. These are my references. Thank you so much for patient listening.
Thank you so much for that very interesting presentation. And there's a big support from the audience. Thank you very much. Okay, now we go back to Vietnam, where Dr. No is going to be presenting about a rare case of coronary artery fistula draining into the left ventricle in a hypertensive woman.
Hello everyone, my name is Huỳnh Thị Như Ngọc, internal medicine resident from Penn University, Vietnam. Under the mentorship of Associate Professor Đỗ Văn Ký, I am pleased to present to you a rare and interesting case about multiple coronary artery fistula into the left ventricle. I have no disclosures to declare. Now let's begin. So I have a 67-year-old non-smoking retired teacher. She was on amlodipine 5 mg daily for her long-term hypertension, no other comorbidities, no surgery history or drug allergies. She presented with worsening chest discomfort and palpitations. She first reported the non-radiating left side chest pain for over the past 4 years, which recently increased in frequency and severity. She also described episodes of palpitations lasting for several hours, accompanied by mild shoulder breath. She had not previously sought medical evaluation for these symptoms. Upon the ED presentation, vital sign was normal. Cardiovascular and lung exams were unremarkable. These are her initial workup. Baseline EKG revealed brief episode of supraventricular tachycardia. Cardiac biomarkers and routine lab tests were within normal limits. Transthoracic echocardiography demonstrated preserved biventricular function without any structural intracardiac shunting or valvular abnormalities. She also got a 24-hour EKG, revealed frequent premature atrial contractions and brief episodes of supraventricular tachycardia. This is her, given her negative biomarkers and also the normal echo findings, coronary CT scan was indicated. So now we can see a coronary artery fistula from the left coronary system into the inferolateral basal left ventricular wall, with fistula orifice measuring around 7 millimeters. A significant dilation of the left coronary branches with a maximal diameter of 12 millimeters. And also we noted an intercoronary connection between the left and the right coronary arteries proximal to the fistula. Here is the 3D reconstruction image where we can better visualize the entry point of the fistula into the left ventricle. Based on the abnormalities that we detected from the coronary CT scan, coronary angiography was indicated for more detailed evaluation of the coronary malformation. So the angiographic results were consistent with the previous findings from the coronary CT scan. We have a large complex coronary artery fistula originate from the distal LAD, RCA, and LCA, all of that draining into the left ventricle. An intercoronary connection between the LAD and the RCA also noted proximal to the fistula. So the final diagnosis here is multiple coronary artery fistula into the left ventricle on a patient with long-term well-controlled hypertension. Due to the financial constraints and also the patient reference, no intervention or surgical procedure was performed on her. She continues to with conservative management with beta blocker and follow-up after 3 months. She was stable, reduced chest pain and palpitation. So multiple coronary fistula was extremely rare disease, and also the lesson we learned from this case is that also always remember to think about coronary artery fistula in patient with a typical chronic chest pain like this patient and palpitation with inconclusive non-invasive tests. The patient's chest pain and her arrhythmia are likely due to the coronary steal phenomenon. So recognize this disease is crucial, especially in patients with unexplained symptoms and inconclusive non-invasive testing. In such case, coronary fistula should consider into the differential diagnosis, and we need further testing like coronary CT scan and also coronary angiography for the definite diagnosis. Treatment for this disease vary based on the patient's symptoms and the resource availability. That's all. Thank you for your attention.
Thank you very much for that interesting case with interesting images. Now we're going to go over to Dr. Natu's presentation from India, where we're going to see a case of poem syndrome.
Good evening, everyone. I'm Dr. Avni Natu, PGY3 at the Department of Radiology, State GS Medical College and KEM Hospital from Mumbai, India. I'll be presenting a case of poem syndrome. I have no disclosures. A 35-year-old man presented to our hospital with left shoulder pain for the past 6 months and gradually progressive bilateral lower limb, tingling, numbness, and weakness since the past 2 months. On physical examination, he had painless left axillary lymphadenopathy and a hyperpigmented rash over his extremities. A frontal radiograph of the left shoulder was done, which showed moth-eaten type of lytic destruction involving the left glenoid, coracoid process, and lateral part of spine of left scapula with intermixed patchy areas of sclerosis. The lesion showed a wide zone of transition, looked aggressive with an adjacent periosteal reaction. We thought that there were few suspicious areas of cortical breach along the inferior margin of the left scapula, which was confirmed on the coronal section of the CT shoulder in bone window. An ultrasonographic examination of the left shoulder was done, which showed a heterogeneously hypoechoic lesion with internal arterial and venous vascularity in the glenohumeral joint space. The adjacent bone showed cortical irregularity as shown by the arrow. An MRI of the shoulder was done, and a proton density fat suppressed image in sagittal section of this MRI shows a PDFS hyperintense lesion epicentered in the left scapula with invasion into the adjacent soft tissues. The lesion also showed patchy areas of diffusion restriction, and there were multiple enlarged lymph nodes seen in the left axilla. On a coronal non-contrast CT scan of the abdomen in bone window, we could see multiple tiny sclerotic lesions in the visualized lower dorsal lumbar vertebral bodies and the pelvic bones. A CT-guided biopsy of the left shoulder lesion was done, which on histopathological examination showed a plasma cell tumor. On ultrasonographic screening of the abdomen, there was hepatosplenomegaly with bilateral bulky kidneys. In view of the lower limb tingling and numbness, a nerve conduction study was done, which showed features of chronic inflammatory demyelinating polyradicular neuropathy. In view of the hyperpigmented skin lesions over his extremities, a serum ACTH level was done, which was elevated. To rule out involvement of other bones in the body, a bone marrow aspirate from the iliac crest was done, which showed normocellular bone marrow. In view of the solitary plasmacytoma with multiple sclerotic bone lesions and other findings like polyradicular neuropathy, organomegaly, endocrinopathy, and skin changes, in a treatment-naive patient, a diagnosis of Poem syndrome was made. Poem syndrome is a rare multisystem disorder caused by an underlying clonal plasma cell dyscrasia like a myeloma or a plasmacytoma. In our case, our patient met both the mandatory criteria polyradicular neuropathy, and a monoclonal plasma cell proliferative disorder, one major criteria, which was sclerotic bone lesions, and three minor criteria, which were organomegaly, endocrinopathy, and skin changes. The management of Poems syndrome is dependent on the presence of an isolated plasmacytoma or disseminated marrow involvement. Our patient underwent targeted radiotherapy and is now doing symptomatically much better. Take-home points of this case are presence of a plasmacytoma with additional sclerotic bone lesions in a treatment-naive patient warrants further investigations for Poems syndrome. This case highlights the importance of high degree of clinical suspicion and multimodality investigations in accurate diagnosis of rare cases. Thank you.
Thank you very much for that very interesting case of Poems syndrome. And thank you very much for the audience for sticking with us and for supporting your participants so far. We have come to the last case. So for the last case, we're going to finish up with Pakistan, where Dr. Azam is going to present about a curious case of the missing humeral head. After that, we're going to go to the voting and the judging. So let's look at this last presentation.
My name is Dr. Nadia Azam and I am resident diagnostic radiology, Allama Iqbal Medical College in Hospital Lahore. Today I will share with you a very interesting case, and it goes by the name A Curious Case of Missing Humeral Head. So my presentation outline this is my presentation outline, and we will discuss Hello, my name is Dr. Nadia Azam and I am resident diagnostic radiology, Allama Iqbal Medical College, Now Hospital, Lahore. And today I'll be discussing a very interesting case. It goes by the name A Curious Case of Missing Humeral Head. So let's see first my presentation outline. We will discuss the history, examination, investigation, and management. First things first, history was my patient was 45-year-old female. She was non-diabetic, normotensive. She was having pain in her, she was having left shoulder joint swelling. It was associated with minimal pain, but there was a very marked decrease in the range of movement in her shoulder joint. Her labs were, blood work was normal, TLC was 7.5, ESR 41, and CRP 0.2. With these complaints, patient was advised by her GP to get X-ray of the shoulder joint done, and she came to our department for the X-ray. This is the X-ray AP view of the left shoulder joint, in which you can appreciate that the proximal shaft of humerus shows a sharp post-amputation like sharp demarcation. There is loss of glenohumeral articulation. There is no humeral head appreciated. Marked erosive changes are noted in the glenoid cavity. You can also appreciate loose bodies within the joint cavity. Rest of the scapula, clavicle, and ribs were unremarkable. So this was actually quite shocking, and we were first thinking about it could be either chronic inflammatory process, but since the labs and the blood work was normal, so it was rejected. So next we went on to rule out any neoplastic process, and for that first we did a contrast enhanced CT chest, abdomen, pelvis of the patient done, and these are the images of the staging CT, in which you can appreciate that on the left side the humeral head has been displaced forward by the marked joint space effusion. For reference, this is the normal right-sided shoulder joint. There were loose bodies within the joint appreciated. Here on this cornel view, you can also appreciate similar findings. This is the normal right-sided shoulder joint for reference. So after the contrast enhanced CT findings, there was no axillary lymphadenopathy, no surrounding, no metastatic deposit anywhere in the body. So a neoplastic process was ruled out to some extent. Then we went on to get MRI of the left shoulder joint of the patient done, and these are the MRI images. These are the T2 weighted corneal and axial slices in which you can appreciate there is marked debrinous joint effusion. The sclerotic and sclerotic changes are noted along the humerus and the glenoid cavity, and you can also appreciate loose bodies within the joint space. This is the post-contrast MRI of the patient in which you can appreciate a rim enhancing effusion, and this is the humeral shaft that shows amputation like demarcation. So after these MRI findings, we were left with the differential of neuropathic arthropathy. So to further investigate, and as we dig down deeper, we decided to get MRI cervical spine of the patient done, and I'll share the images with you. These are the sagittal sections of the MRI cervical spine in which you can appreciate there is somewhat a downward descent of the cerebellar tonsil, and you can appreciate crowding of structures at the level of cisterna magna. You can also appreciate syrinx formation, which is starting from the C1 vertebra and extending up to upper thoracic spine. So actually after this investigation, we came to the conclusion that it was actually a case of carry 1 malformation, and due to the long segment syrinx throughout the spinal cord, there was deficient proprioceptive sensitivities in the shoulder joint of the patient, and the repetitive micro trauma led to development of Charcot arthropathy of the patient. Her right-sided shoulder joint was also at risk, and the further management was as discussed by the ortho department. It was conservative management and shoulder arthroplasty. Case courtesy Department of Diagnostic Radiology, Genoa.
Okay, there you have it, everyone. That was all of our 20 interesting case presentations from 6 different countries. We appreciate everyone who presented these cases. They're all interesting, and all the audience was very supportive. Now we're going to go ahead and take a 10-minute break where you're going to get a chance to vote to your favorite cases. There's going to be a poll that's sent to you where you're going to be voting for your favorite cases, and our judges will be judging these final 20 finalists. Thank you for sticking with us. Are you ready for results? Okay, so the winner for People's Choice Awards is Dr. Mohammed Yusuf from Pakistan. Congratulations, Dr. Mohammed. You have been awarded the People's Choice Awards. And in third place, we have Dr. No from Vietnam. So thank you, Dr. No. You have won our third place. So that's from Vietnam. On second place, we have Dr. Kar Bilal from Pakistan, with this case of thalassemia, as second place. Congratulations, Dr. Bilal. And on first place, last but not least, we have Dr. Chahal from India, who presented to us with an interesting case of gallbladder cancer. She wins the day. So thank you everyone for participating, for voting. We had over 300 votes, and the People's Choice Awards was won by Pakistan. We have 3 different countries winning these case competitions, and we appreciate everyone's participation. I'm going to give the floor to the leaders of this project, Dr. Farouk, Dr. Hansel, if you have anything else to say.
Sure. I'll speak for Hansel as well. He had to go attend to some stuff. And so here we have it again, another year, another case competition focused in Asia. We appreciate everyone for participating, for hanging out with us on a Saturday morning. your time and Friday evening our time. And again, thank you to everyone you see on camera and some people not on camera who help put this together every year. We appreciate it. Remember to keep saving your interesting cases and start thinking about next year already. And we have a survey, correct? Yeah. Fill out the survey, please. All right. Well, have a good day.
Give us your feedback based on your survey, and we'll send you a follow-up email with our surveys. Thank you for participating, and we look forward to your feedbacks. Thank you, everyone, for joining us, and we will be ending the case competition by this.